the arrival of the chairperson. But in any case, our star speaker is with us, so I don't think so that we'll be doing any injustice. So this session is primarily on nAMD, and nAMD is a frequently encountered problem. I think the retina surgeons see it every day in and day out. Even the comprehensive ophthalmologist sees, but he is focused only on the NTA segment, and then those patients comes to us with unsatisfactory visual recovery. But believe me, with aging population all across the globe, with healthcare services improving, nAMD problem is going to increase. The only silver lining in this nAMD is that things which were untreatable or unmanageable 2 decades back, now we have a plethora of agents available which can help the patient. So not only we today talk of maintaining vision, but there is expectancy of patients to improve vision also, because they at that fag end of their life want to see, want to read, want to see the currency note and visit bank, whatever. So anti-VEGF agents have revolutionized the management of nAMD, but the expectancy of patients is increasing because patients get fed up of repeated visits. In came Macugen, but Macugen didn't work at all. It was similar to more or less PDT. Result-wise, the graph never climbed up. So when ranibizumab got introduced by the famous Marina Anchor trials, so patients started improving. Now, what I call first generation anti-VEGFs, that is aflibercept and ranibizumab or even Avastin off-label, they did benefit a lot of patients. That means patients, significant number of patients had improvement of vision. But there was always an unmet need. That came from patients' responses, that how frequently we keep calling the patients. You see, our clinics were flooded with every day, so many patients, injections, consultation, OCT, relatives coming. So that led to another thought process that can we, or this now that technology is available, reduce the number of visits, reduce the the cost to the patient ultimately. So in came this second generation of anti-VEGFs. So first generation I said was aflibercept and ranibizumab or even Avastin. The second generation, which I think add D means duration of action or durability increases. So then came this brolucimab. But brolucimab, there is always a fear factor, always, because the label itself said that IOI and retinal vascular events can occur. Then that faricimab got launched nearly more than 1.5 years back, and every one of us are gaining experience with faricimab. Faricimab has additional D. Apart from duration, it has dual mechanism also. So we have with us the master from Malaysia, Dr. Kenneth Fang, who has vast experience, much more than what we have, primarily because we have exposure since January only. So all of us, what you see panelists here, they have, few cases. Somebody has done 20 cases, somebody has done 30 cases. So we have collective experience of, I think, more than 600, 700 injections. But we want to hear from you, from, like I said, horse's mouth, the real world. We are all aware of the, controlled trials, but the real world is one thing which, cements that place. Yes, faricimab is the way to go, and how should we approaching our patients, whether treatment naive or whether resistant cases only. Is it economical sense to, use this as a first line of agent in nAMD or not? So, if everybody is, we'll request Dr. Kenneth to please upload his slides. So I'll request Dipinder, you also join, because I feel lonely here.
Thank you very much, Dr. Verma. Thank you to the AIOS for the kind invitation. Yes, I'm very honored to be here. I've given a couple of talks previously online virtually to the Hyderabad Ophthalmology Society and also the Bombay Ophthalmology Society. I think you were also chairing that event. So it's a pleasure to be in Kolkata in person, and thank you all for spending time with us. So before I go into the real-world evidence for Vabysmo, I just want to remind you of the pivotal registration trials which allowed Vabysmo or faricimab to be registered worldwide as one of the main drugs for neovascular AMD. So this is the initial study design whereby they had 4 loading doses, and after that at week 20 and 24, the patients were allowed to be put on a patient treatment interval, basically a treat and extend type protocol whereby if the patients had no fluid, no worsening of vision, they were allowed to be extended by additional 4 weeks and up to a maximum of 16 weeks. So in the first year, patients were on faricimab in the clinical trials were allowed to be pushed all the way up to 16 weeks in an effort to show and prove durability. The comparator arm was aflibercept according to the label, where they had 3 loading doses of 2 milligram, and after that 8 weekly fixed dosing for the next 2 years. So you can see here with the faricimab fixed dosing versus the faricimab personalized treatment interval dosing, the results were fairly similar. So they were non-inferior to both arms, with a gain of up to 4 letters at 2 years. The most important thing to note is that after 2 years for the entire study, 15 aflibercept injections were given compared to just 10 for the faricimab injections, for number of injections, because more than 50% were pushed up to 16 weeks of dosing. And there was comparable reductions in the central subfoveal thickness all the way up to 2 years. There was no difference between the 2 arms at all. Again, a reminder of the number of injections required, which is approximately half that of aflibercept. Now, when we analyze patients who are treated with neovascular AMD for drugs, anti-VEGF drugs, we also look at their fluid compartments. And one of the most resistant, important fluid compartments is the intraretinal and subretinal fluids. There's general agreement that PEDs tend to affect vision less than these two. And you can see in the purple boxes, the majority of patients who are on faricimab had the absence of subretinal and intraretinal fluid at all the way up to in the initial loading doses. So the effect was very quick. Now, the other thing is we want to look at the first absence of IRF and SRF. So basically, by the week 8, after 2 faricimab injections, 80% of patients had reduction or absence of IRF and SRF compared with aflibercept, which needed an additional month to achieve the same result with 3 injections. This slide is quite important because it segregates your patients into the number of patients that are on a particular dosing interval. And at the first year, 80% of patients were either 12 or 16 weeks dosing, and at 2 years, the same number of patients remain. And you can see the majority of patients, 63%, were maintained at 16-week intervals, which is 4 months. 3.5 to 4 months, which is very significant in our current era of anti-VEGF, where the majority of agents only last between 8 and very rarely at 12 weeks. What about in our part of the world in Asia, where we get a lot of PCV? Similarly, in Malaysia, I treat about 30-40% of my AMD patients are really the PCV subgroup. And this was from the Tenaya Lucerne study, where they found 19 patients with PCV based on ICG guidance, and at 2 years, 85% of patients were able to be extended out to 16 weeks. And at the first year, you can see the majority of patients who were treated with Vabysmo had the absence of polypoidal lesions compared to aflibercept, 42% versus 73%. And PED, we all know PEDs are the most challenging category of AMD patients to treat. And again, we found that in the comparative head-to-head study, there was a significantly better reduction in PEDs at the first 3 months of treatment compared to aflibercept. What about safety? This is a big issue because other drugs like brolucizumab have had reported up to 5% rates of intraocular inflammation, and worldwide there's been a massive reduction in usage of brolucizumab because of that. So there was no reported events of IOIs, or more importantly, no retinal vasculitis. The intraocular inflammation was 3% with the faricimab and the 2.3% in the aflibercept arm. But there was no retinal vasculitis events in either arm of drugs. So going back now, I'm just going to show you the real-world study. I've been using Vabysmo since October 2022, when it was available as a special named patient basis. It was approved in Malaysia in July 2023, so about 6-7 months before India. So I'm going to show you what I did with all my first batch of patients, and I think, as you know, these are all switch cases of neovascular AMD. 28 patients or 28 eyes. We've got more than 1 year data now, but this is the first 8 months. So the average age was 65, predominantly female, and all of them was treatment switch. All of them had fluid present, either IRF, SRF, or PEDs, and was significantly thickened central subfoveal thickness about 422 microns. With just one injection of faricimab, we found a significant improvement of up to 3.75 letters compared to previously. This is an average. A reduction of central subfoveal thickness of 130 microns, which was statistically significant with just one injection. So looking at the different fluid compartments, whether it's IRF, SRF, or PED, all patients had reduction. And you must remember, these are all patients that have been treated for many, many years with a variety of agents: ranibizumab, aflibercept, brolucizumab, Avastin, PDT, steroids, everything. So they've had everything done before we switch them over, and these are the most challenging cases to treat. So again, we analyzed the subgroup, and you can see the light purple and the light blue boxes, whereby more than 50% of patients all had reduced or resolved fluid, compared to just 4 to 14% increase. So 14% of patients had a slight increase in the PEDs compared to the other compartments. So we had, with just one injection, I think all of you will see once you start using it, and we're going to share with our panelists later, a significant reduction in the fluid and improvement in the visual acuity. So I'm going to end with 3 quick cases before we go to the panel discussion. This was an 85-year-old male, history of hypertension, hyperlipidemia, AMD for 20 years in the right eye. He's had previous cataract surgery, but when he presented to us, we had diagnosed him in September 2020, and he was treated with, sorry, I apologize, he had hypertension for 20 years, not AMD for 20 years, and he was treated with 5 initial aflibercept doses, followed by 8 brolucizumab, so a total of 13 injections before we switched him over to Vabysmo in February 2023. So this is the initial base visit in 2020 when he first came to see us. You can see a large PED with intraretinal and subretinal fluid. Aflibercept was given. It worked. There was some reduction in fluid, but a PED was still persistent. And he was continued on 5 to 8 weekly doses, depending on how these patients turn up. You know, in real life, it's very hard to force them to come at the regular intervals. After the 3rd dose of aflibercept, the patient wanted a more durable agent, and in 2021, the agent was brolucizumab, so he was switched over to brolucizumab, and then maintained at about 8 weeks intervals with brolucizumab. And again, throughout the treatment with brolucizumab, we could never ever get rid of that PED. And finally, when we had Vabysmo available, we offered this to the patient in February 2023, and after just one injection of Vabysmo, the PED was gone with a significant improvement in vision. So you have to understand these patients has had 13 anti-VEGF injections over the last 3 years with persisting metamorphopsia and still fluid present, but with just switching him over to Vabysmo, we managed to resolve all that, and the second one was given, and he was maintained at 12-week intervals because the patient was coming from far away. They could not come any sooner. Here's a second case, a more typical case that you might see next week when you go back to work. 66-year-old lady, macular degeneration for 1 year, and she was initially treated with 3 aflibercept injections in 2022. So when she came to see us in February 2023, there was persisting PED. The patient had been observed because of the stable PED, but because she reported a drop in vision and increase in the IRF and SRF fluid, the patient was given an option to switch over to Vabysmo. And after just 1 dose of Vabysmo at 8 weeks, you can see a complete resolution of the PED. The visual acuity was about the same. So we treated this patient proactively because of the increase in fluid, and then the patient was continued on 8 weekly, and again this is off-label. The label suggests you should load them monthly for 4 doses, but again in real life, when you're doing with switch patients, there's no real consensus on how you should, whether you should go them on monthly loading. We can discuss this in a panel discussion, or go back to what they were on before on their previous drug. But the patient, because they requested to come back at 8 weeks, so at every 8 weeks we gave the patient the Vabysmo. And after the second Vabysmo dose, there was some improvement in the visual acuity from 618 to 615. So again, the patient requested to come back every 8 weeks, and we're continuing to give her Vabysmo. Finally, a PCV case, a young lady, 39-year-old, very active, who drives, noted distortion of vision in the left eye since April 2022. Again, she was initially treated with aflibercept, baseline visual acuity of 6/8, and this was the baseline in 2022, resolution of the subretinal PED fluid after first aflibercept, but even after 1 month, there was the appearance of recurrence of PED. So the patient came back to see after 3 injections, and then noted that we offered her the option to switch over to Vabysmo, and then in May 2023 she had increasing PED height with subretinal fluid. First dose of Vabysmo was given, and then 8 weeks later there was complete resolution of both fluid compartments, and this patient was maintained on Vabysmo for 8 weeks. So with that, I'd like to end, and then I'm happy to answer any questions. Thank you.
Thanks, Dr. Kenneth, for sharing your data about real-world scenario about Vabysmo. All your 3 patients were switch patients.
Yes. Yeah.
So
yeah, they're all switch patients.
Any treatment naive experience or?
Yes, we are compiling our list of treatment naive patients now that we have full approval in Malaysia. But before the official approval, we only allowed to use it for switch patients.
So in switch patients, you do not resort to loading dose. Switch patients are only Q8 or Q.
Well, that's a common debate in all the AMD sessions. So what do we do when we switch? What is the ideal? In an ideal world, you should really give them the full 4 monthly loading. But because they've been treated for so long with multiple injections, perhaps the cost is an issue. So we try and compromise, and my advice is between 6 to 8 weeks. And so far, I found that even at 8 weeks follow-up, there's still the macula is still dry.
So what I noticed was that a lot of these, all 3 patients had a big PED along with SRF.
Yep.
So SRF did respond to aflibercept, but PED was not responding.
Yes, that's generally PED is still generally the most difficult part to treat. And we feel that that's because of the dual inhibition. I didn't have time to talk about the biology of the Vabysmo agent, but it not just blocks VEGF, but blocks Ang2. So a lot of AMD patients who have been on anti-VEGF for many, many years, and then when we switch them over, we find quite an impressive response. So we believe the Ang2 pathway does play a role for these patients. And then again, in Malaysia, we just had DME approved for use for Vabysmo. And again, a lot of our recalcitrant DME patients are responding very well when we switch them over.
DME patients? For
DME, yes. Yeah.
So we welcome Dr. Mishra. So he's the chairperson of this session. Dinesh, you also join. Come to the. So because now he just finished his talk, having some discussion about real world scenario. So anybody would like to ask any question? Yes? Yeah.
How anti-VEGF can...
Who is there? Who is there?
Online.
How anti-VEGF can subside the PED?
Can you please stand up, introduce, and what is your question?
I am Professor L.K. Mondal from RIO Medical College, Kolkata. How anti-VEGF can resolve the PED? What is the mechanism?
Oh.
He says, how does PED?
I know. I mean, that's a Nobel Prize question. I mean, to be honest, I mean, it's all the leakage of the fluid in all the compartments of the retina is driven predominantly by upregulation of VEGF-A, but there's many other factors: VEGF-B, VEGF-C, and also angiotensin, Ang2, the Ang2 pathway as well. So I think how it restores it is by normalization of the retinal vasculature. Pericyte remodeling is very important. I think you'll find that because Ang2 is inhibited earlier downstream, once the pericyte remodels, the fluid compartments tend to normalize better. So you find that when you have a PED, a large PED patient, if you give them, for example, off-label Avastin, that doesn't tend to work as well. Whereas a more potent anti-VEGF agent like aflibercept, which is a VEGF trap, initially, many years ago when it was launched, a lot of people were switching to it and reported some good responses after switching. But then after time, these PEDs recur again. So there's some resistance or to that.
So I think the first thing is you must understand that RPED is actually a sign of an active disease. And it's when you are treating it, what it means is that you're not being able to treat it completely. The fact that you never get a normal architecture, in most cases, is a sign that you're never going to treat this completely. And when you've treated it, if you really look at it, what happens? You'll see that it becomes multi-layered, becomes more solid, which is basically a scarring process occurring under that PED. So that's why for example, with ranibizumab, we never used to get we were never running after the PED.
You see that
even today, we don't run after the PED. We are not trying to treat the PED. But if the combination of resolution of PED gets associated with a longer duration of action, it would gel that you're getting a better regression of the disease process. And that's all what it is, really.
You see, all of us have been treating ARMD, but the issue is that till the time this second generation anti-VEGFs came, we never used to have this resolution of RPED coming. Or maybe it will, but we have seen this, Dr. Kenneth also showed that with aflibercept, with 8 injections in the first patient, nothing was happening much to PED. But I have seen this happening with brosumab also and with faricimab also, that PED starts to collapse. And therefore, that is the reason, because in PCV, we noticed that Dr. Kenneth showed that maybe the response rate in compared to nAMD is 10% higher. Maybe it becomes a drug of more choice than the other agents.
Actually, the hope...
Because PCV, as you know, characterized by multiple or bilobed or thumb-shaped PED. So there maybe the response of this newer agent, faricimab, may be better compared to ranibizumab.
Actually, the hope is that because faricimab works on Ang2, and that is responsible for decreasing the amount of fibrosis which is created. Now, you see, it's like any disease process, healing occurs. Now, if the healing occurs in an area of your joint, healed, but the function's gone. Same thing is with the eye, healed, but the macula is gone. Now, what we are wanting is that healed with virtually no scarring. And the hope is that with Ang2 inhibition, you would get a situation where you have less fibrosis. So not only do you take care of the CNVM by the VEGF treatment, anti-VEGF treatment, but you take care of the fibrosis by the Ang2. And consequently, you may get a better resolution without the scarring and therefore a long-term better outcome.
So I have one question for Dr. Kenneth. See, it's a fairly new drug, with limited exposure, especially in our country. Will you like to use as a first line of drug first? Secondly, what about cases when you have a one-eyed patient? Thirdly, in case of a concurrent cataract surgery, would you like to use it? Because when brolizumab was also launched, there are a lot of apprehensions that because of the IOI. Few cases have been reported with this faricimab also. The article which was published in JAMA. It could be something different also. It could be endophthalmitis. But with the backdrop of having IOI in these cases, would you use it in the following condition which I asked you?
Yeah, thanks. So I think one of the key things to understand is more than 1.8 million doses of faricimab have been given to date worldwide. So we're looking at North America, Europe, Asia, rest of the world. So I think in terms of number of drugs, it's considered a blockbuster drug because against heavy competition, and they've still managed to have a lot of usage. So number one, yes, it's licensed as a first line in Malaysia and around the world. So I would use it first line, no issues at all. Secondly, the second question was about one eye patient, definitely, because with a one eye patient, you want to reduce the number of injections but get the best effect. So durability is important, because the more number of injections you give an eye, the higher the risk of endophthalmitis, the cumulative risk over time. So you might give 40, 50 injections, they're going to get it one the other. So the third question, using faricimab in combination with cataract surgery, well, again, that's off-label usage. So you can choose whatever drug you want. Yes, I think if the patient can afford it, why not? If the indications they have active AMD, you can't see the macula, you need to do the cataract, by all means go ahead. I always combine it for my DME patients. I do a combination of anti-VEGF when I do the cataract surgery, because that's very important to prevent post-operative CME.
So do you mean that you combine cataract surgery at the same time you give this injection?
Yeah, if they have active AMD, I always try and dry the macula extensively. Again, with all the modern swept source OCTs, they can visualize the macula very well to treat cataract. So do not rush into the cataract surgery until the AMD is settled. Unless it's an only eye patient, they can't see at all, or they are whatever reason. So that's very rare. But the more common situation is DME. Because these DME patients, they need some sort of anti-VEGF or steroid at the time of surgery.
The other question I wanted to ask was, that you showed good drying effect.
Yeah.
Very good drying effect. Is drying effect very important, that all drying leads to vision improvement? Or because I noticed that vision improvement was not much.
But
so what is the advantage of having it dry?
Correct. I mean, you have to understand, because the concept of fluid compartments was created because we reached a threshold level with what previous anti-VEGFs could achieve. So we come to a point where we analyze that, okay, PED patients, you can analyze, you can say that it's stable. We don't need to do anything, we just observe. But in reality, as what you mentioned, it is a measure of activity. Why is the PED there? That shouldn't be there. So because that was a ceiling effect with what we could do with whatever drugs we had. So I think now, because of the drying effect, I think if we can dry it as much as possible, normalize it, give them better long-term visual outcome. In my patient, the last patient, she took about 8 weeks before vision actually improved, even despite the resolution of the PED.
Yes, sir.
See, the main constraint about use of faricimab, I have appreciated that the resolution of PED is an important differentiating factor when you are switching over. And that is one of the reasons why we switched over. We have noted what Dr. Dinesh has said about the resolution or quietening of the disease process without much of scarring. I am trying to find out, you have had a PED subsidence. Now, after a while, can you switch back to the original anti-VEGF? Means, once the PED is resolved, how long would it take without faricimab?
Yeah, again, it's a difficult question to answer, because I find generally speaking, the younger patients tend to have more challenging PEDs. So I have a 50-year-old lady that has about 70 aflibercept injections, 70, with persistent PED over many years, and then I'm switching over to Vabysmo. The PED does resolve, but she requires the Vabysmo every 4 weeks.
The reason why I asked was, it is an expensive thing, which we can...
No, Pangarkar, what my concern was that why once a patient has responded to Vabysmo, why do you want to switch it back to, say, previous anti-VEGF? Because of cost, you are saying?
Yeah.
But economically, because you see, I was coming to that question. This drug has advantage of duration also.
Yeah.
If you want to shift it to, say, any biosimilar of ranibizumab or whatever, if you work out a yearly cost, believe me, this agent comes out cheaper, in fact.
Actually, that was going to be my next question. So what are the unique selling points you would say, so to say, to convince us that faricimab will be a better choice on all these three parameters? First, the effectiveness, better resolution, better response, and economic criteria.
More important point apart from this, you see, response may still occur with, you see, one of my first patient which I gave faricimab injection was because he's a physician and wife is a nurse, and he says, doctor, every time I have to come from such a long distance because the duration gets increased. So once the durability is more, less visits, less air travel, all these things come down, and economically it makes sense because of this duration. Maybe because his patient showed Q8, but by and large the advocacy is that after you have achieved response, the duration may be Q12 or Q16 also. That is the advantage.
See, actually what I'm looking for, and which to answer your question, if with faricimab you can end up, see, we know that 80% of these patients will end up with Q12. So once in 12 weekly injection. But the question is that will we get that consistently? Like, can I say कि मैं आँख बंद करके भी, if I give the injection, come call the patient at 11th week, I can give the injection. If, which we don't know right now, but for of these patients whom we have at 12 weeks or more, around 50% we definitely know, but we don't know which 50% who will not need to get less than that. But there will be some 25% of patients who may go to 12 weeks and 16 weeks, but come down. So you can't say, no, come only at 11th week. That is the issue. Once we know consistently which patient I am giving every 16 weeks, right?
Dinesh, that's a process of study.
No. So what I'm saying is once I've given, that's what I'm trying to say. If I've given 3 consecutive injections and I know I don't need to go below 12 weeks, then this is the patient where you could consider that I can call you at 11 weeks. But here there's a caveat. Actually, the one who's at 12 weeks can be taken to 16 weeks. If you can get the patient to 2 16-week consecutive intervals, chances are he's cured. You don't need to shift to another drug after that.
So that statistics, that only follow-up will tell which patients, you see, 20% patients still may require lesser frequency, lesser,
So the change you're talking about is only needed in patients who've gone to 16 weeks. After 16 weeks, he doesn't need treatment, so there's no need for change. And the fellow who's at 8 weeks, you can't change back.
Yes, Devdulal.
So, great talk, Dr. Kenneth. I'm Dr. Devdulal from Disha Hospitals, Kolkata. My question to Lalit sir and Dinesh sir also. Sir, how do you counsel your patients for faricimab?
You see,
it takes longer and longer, but more agents, obviously. So you have to run through every single agent in the market. Otherwise, you're not giving full disclosure to the patient. So it is a hard thing every time a new product is launched. Thank goodness it happens only every 8 years. So that, but they'll ask you what's the best. So you run through all the options, the cost, and then the last question they always say is, doctor, what do you suggest? So that's how I approach it. But if they will ask me tomorrow when I go back to Malaysia what I'm patient, it will be faricimab first line because I know that I can extend them up quicker. Yes, cost is a minor issue. Most patients actually, they just want the best for their eyes. So if cost really was an issue, they would just go for bevacizumab, which is the cheapest agent. But they know they're going to come back monthly for the next 2 years because it really does not have the durability effect.
So you tell your patients that patients who are maintained ultimately on faricimab, this is what I tell, but as the response occurs, and once the disease stabilizes, as Dinesh was saying, say 2-3 injections, then you are pretty sure that this patient will require at best 3 injections or 3.5 in a year. So that is the biggest selling point, that instead of monthly, you will shift to maybe 3 or 4. But that will take time. You can't tell your first patient today that I am giving 1 injection today, now you come back after 3 months. You can't. Because that's a concept. Statistics are told that after 4 doses, 80% will shift. As Dinesh was trying to say, till the time you have stabilized the disease, then only you can say that you will require Q12 or Q16. Before that, it will not. Because there are no biomarkers available where you can say this patient will require or which 20 patients will not require. So that's a $1 million question, in fact.
See, so yes, basically, at most of the, I'm a conservative surgeon. I'm not so aggressive. I only take up for change to faricimab patients who are recalcitrant. And the way I go about it is, and I tell you a recent one, a patient who was also got brolucizumab. The patient previously was recalcitrant, was given brolucizumab, did respond, needed another aflibercept. Now came back, it was 5 months later. And then now, this is the classic situation where you need to counsel. And I told the patient, I'd already told brolucizumab, risk of intraocular inflammation. I told the patient, this drug, the chance of intraocular inflammation is negligible, no different from what you have with aflibercept. The duration of action, we can possibly take you to the same 3 months, so it's worth trying it out. And it's your choice. And the patient in this particular case actually said, since anyway I got the aflibercept after 5 months, let's try that once more. So to answer the question, sometimes when you do shift to a newer drug, you can get a longer duration of action, which is what happened to that patient. And so you tell the patient, I'm not doing it for better vision return. I'm actually doing it for better duration of action, but I am actually looking for how the patient changes. So I do a very close follow-up, first weekly and then every 3-4 weekly, and see both the things, rate of drying. If I get a better rate of drying, I tell the patient that also, that the rate of drying is faster, so it may be a better drug for you. And the second is the amount of vision improvement. So that is the second counseling. The first counseling is only in terms of durability and lack of a chance of an intraocular reaction.
So Babula, this duration becomes important primarily because possibly compliance will improve. You see, if you tell your patient that keep coming, this patient, like his patient came after 5 months. So sometimes patient drop down does happen. 50% patient will drop down if you keep calling. So because of duration, how I counsel is, like efficacy may not be dramatically different between two drugs, or drying also may not be dramatically different. But duration is one thing which is weighing heavily in favor. So I tell them that आपको कम आना पड़ेगा, you will have less this thing.
My question is basically with that one.
Do you go for a loading dose, counsel for a loading dose in our context?
Yeah, all naive patients need a loading dose.
Recalcitrant patients?
Yeah. I only take recalcitrant patients, so so I don't give a loading dose. But I assess the response and decide whether I need a second injection or not. With brolucizumab, I used to keep a margin of 8 weeks. With faricimab, by 6 weeks, I'm willing to take the second injection.
Yes, Vinay.
Hi, I'm Dr. Vinay Garodia from Delhi. So my question was, knowing by the mechanism of action, I would expect a better response with faricimab rather than more duration of action. But what I'm hearing from industry people also and everyone is the duration of action is more. I just want to understand, how do you explain the duration of action is longer? Because still I understand that I cannot explain that to the patient. One, what is the theoretical basis of longer duration of action? And second, what is your personal experience about the duration of action? Because you have used it for a long time. So that's what my question is. No, I'm still
so the duration of action, I had an anecdotal case, February 2023, one injection. Patient was told to come back at 8 weeks, but he didn't come back until 24 weeks because, so they can extend out. I've had patients extend out to 24 weeks. As to why the mechanism of action, I can't explain it biologically because I'm a clinician, but I mean, this is something that we've noted worldwide about the durability. Definitely, we have another subgroup analysis whereby we showed at 2 years in that if you continue the PTI interval, you can actually extend another 30% of patients up to 20/24 weeks. So that's another revolutionary mindset, which you could potentially only see them twice a year. So that's what we are seeing with our patients.
The study that we quoted was actually not the correct study because their ILIA was fixed at every 2 months interval.
Yeah,
so
of course.
It's difficult to comment on that basis.
So the whole point when a new pharma company plans a clinical trial, they're always going to try to maximize the evidence for themselves. So I completely agree with you that it's unfair to aflibercept that they were stuck at 8 weeks, but that's a label in Malaysia as well and worldwide. So, but again, if you want to turn the coin the other way, when they are looking at other ways where we have real-world studies comparing treat and extend aflibercept versus treat and extend faricimab. And there's a few papers being presented that showed that there was a more durable effect with faricimab compared to ILIA. More percentage of patients could be extended up to 16, 20, 24 weeks compared to aflibercept. And that's with the 2 milligram dose. And that's why the 8 milligram was developed purely they recognized the ceiling durability effect of the 2 milligram. So again, with faricimab, from the very beginning when they were designed, they were looking for a durable agent.
Yeah, one small comment
I
about...
agree. These two studies, Tanya Lucerne as well as yosemite, they're not comparable with regard to aflibercept, because aflibercept was not allowed to extend treatment interval.
Yeah, but Lalit, actually if you see these trials, you'll see aflibercept is still showing a sawtooth pattern, despite the fact that it was 8 weeks, which means that already at 8 weeks, it was inadequate in some patients. Now, you don't see the same sawtooth patient in faricimab, which means that the proportion of outliers, there are some, but the proportion of outliers with faricimab are lower, so it doesn't allow a sawtooth pattern to develop for the group. So that means already with aflibercept, there will be a larger number of patients who would be relative non-responders compared to faricimab. Even though it doesn't, you can say that everybody should have been allowed to develop the PTI interval.
One comment about what you said about Q20 or Q24. Actually, only 80% of people recur at 5 years. So there are 20% who would anyway not recur, as Dr. Talwar was saying. So all those theoretically can achieve Q forever.
Yes.
So that Q20, Q24 would anyway be there for 20%, 24% patients with any drug for that matter. So
actually, you have to be very careful. Yeah. This is where I am against using treatment-naive patients as your way of testing this drug, any new drug. Why? Because actually you know that there are these 25% of patients who need 3 injections and nothing for the next 2 years. Now you're taking the advantage of the response over there and saying it was not needed in 40% of patients for so many years. It wasn't going to be needed anyway in half of them. So that's the whole problem.
Yeah. So I think
it's a very complex, topic, and you can't draw firm guidelines into this. And more, we become wiser by real-world data. Today, Kenneth has presented his data. We also collect data. Then only we become wiser in all these things. Believe me, these percentages are basically statistics. It's not, one patient we can approach. But my question to Vinay, this was that if it is better drying as less of sawtooth, then why not try in first line? Why not try as first line then? If you're so confident that sawtooth is less, Kenneth has showed that efficacy, PED, drying is better, then why not faricimab as first line? With no risk of IUI also.
That's what my concern is.
Yeah.
Sir?
I think longer duration, but I would rather say it's more effective. So that's
One second.
That's where my counseling happens. Right now I'm counseling on it being possibly more effective, rather than saying it might be longer duration, because I still am waiting for the
after 6 months, 9 months, we will be able to show more surety actually.
Yeah. But now
today honestly, we have at least I have experience of only 3 months only, and only 12 injections I have given, but can't say with solidarity at Kenneth because he has more experience than us.
Therefore, I wanted that.
That's the whole purpose of.
I don't think when you start off a drug, you're going to start off on treatment-naive patients. So we are in that phase. We are not in the phase that we can go straight to treatment naive, because first you want to assess a response in a refractory patient. If the refractory patient doesn't give any response at all, I'm not going to change my drug. But if even if in half the refractory patients I get a response, I know this is worth trying in my other patients who are treatment naive. And once I have that experience, I will try it. I mean, it's a normal process. You don't start with something else works. Why should I change in the beginning?
So my take on this is I may still try on naive because of the advantage of duration. I may still try, because if it gives even equivalent this thing, because duration is a factor which may force you to try. Because if you are satisfied with the initial few patients in trying, no side effects, no this thing, then I may still try treatment naive because I want to offer that advantage of duration to the patient.
True, but unfortunately, I don't have so many patients to get a study and treat. If I say anecdotal data of 5 patients, they may be the ones who anyway weren't going to get further treatment.
Yes,
they weren't going to need. So I can't do that as a way of deciding long-term treatment over the entire group. Once I've tried some recalcitrant patients, I know it works in these patients, so I can now extend
to naive patient.
The naive patient. That's
okay. Acceptable.
Fibrosis is the burning problem in ARMD cause.
Yes.
Does faricimab block fibrosis?
So that's what the concept of
Does it inhibit
vascular
fibroscar
stability.
growth factor?
So what he is saying is more the number of injections, more the possibility of fibrosis and all those things. I think Dinesh answered that in the beginning itself.
That faricimab block the fibrosis.
Yes.
And fibroscar growth factor.
Yes, there are experimental studies to show that with faricimab, the combination works to decrease the amount of fibrosis that occurs in a patient. Their experimental work is already there.
Yeah.
We have to see how it translates into practical.
In the DME data, they looked specifically at this topic, and they found that faricimab had a much lower rate of epiretinal membrane formation after 2 years compared to aflibercept. So there's some hint that there is a strong antifibrotic effect. I think.
Yes, sir.
Dr. Kenneth, that was an excellent presentation. I am Dr. Nikhil from Delhi. One comment and two questions. The comment is that besides all these advantages, one should also keep in mind the socioeconomics. They have a very good patient support program in India where the patient pays for only 2 and gets 5. So if you're getting a molecule where durability is there, lesser side effects, faster drying at a similar cost, why not offer it to the patient? One question is that during COVID time, I have few patients where brolucizumab was injected for PED, and they were lost to follow-up. They came after 6 months with still a collapsed PED. So what's your take on the PED patient? How frequently the injection should be given? Should we do more of a PRN or keep giving injection in them? And second question, the role of OCTA in all these studies and your findings, ranibizumab, then brolucizumab, then aflibercept, and now this molecule. So what should we note on the OCTA in this? Should we be able to pick up any findings in decision making?
So, Kenneth, first question was about the various schemes given. Obviously, you see, anybody will fall trapped for the scheme because free, nobody minds getting injections free. So whether it is aflibercept or whether it is Vabysmo, in India, Kenneth, for your information, Vabysmo, we patient pays only, it's only for paying patient, not for insurance patient, that you guys first. You pay for first, second is free. You pay for third, rest 2 are free. So that's, that's anybody's this thing. We will definitely, obviously, because then it makes more economic sense also. Because if I'm getting 3 free and pay for 2, then it makes more economic sense for me. Additional economic sense. Additional, The second point was PED. Only PED I would not treat unless patient has metamorphopsia or unless patient has some fluid somewhere else. Only PED I don't, I even open to this thing, but none of us, I think, treat PED. But I agree with you. Both brolucizumab as well as faricimab have huge propensity to collapse this PED, which we never witnessed in ranibizumab era.
OCT angio, I can answer a little.
Yeah, last question was about
OCT angio. What happens is that when you treat with an anti-VEGF, you'll find that the brush border kind of appearance becomes less, and they become more mature vessels, like proper branches of a tree, not small leaves on them. So that is not, that's the stage when you don't treat anymore. It's not so you don't decide when to stop based on OCT angio. You decide when to stop on the basis of the other parameters. But if you follow up regularly, the initial evidence of recurrence can come when new brush borders develop at one edge of those branches. So this is now an early recurrence, and this could be used to decide your treatment. Now, whether there are studies to show whether this happens faster with other drugs and less often with faricimab, I don't know whether you have any experience with that.
Yeah, I think I agree with all the comments made. PEDs, again, if it's a small PED, vision is stable for many, I would leave it and just observe. But when the patient reports metamorphopsia and there's evidence on OCTA or whatever activity, you have to treat it. And we've shown good results where PED seems to respond. And I think going back to, again, what he said about starting out, all of us do the same thing. We all treat our worst patients with the newest drug. And if they respond, that says a lot about the efficacy of it. So I think after 6 months of usage, we immediately, a lot of our physicians in Malaysia, all very rapidly switched over, regardless of the cost. Cost is an issue. It's cheap. I think it's slightly cheaper in India compared to Malaysia. But again, the patients want the best drug they can get and also the durable effect.
So, Karan Gupta, sir.
I'm Karan Gupta, professor in a medical college. I just want to know if the vision is 6/6 and there is a minimal fluid, there is no metamorphosia, will you like to treat?
There is no metamorphosia.
Vision is 6/6, no metamorphosia, and there is a minimal fluid. So will you treat this?
Minimal fluid, which SRF, IRF?
Yes, sir.
Only PED.
Yeah.
6/6, I won't dare also in any eye, not what to talk of, because patient has to realize the benefit also. If I give one injection and suppose something happens, he is going to be after my life in a 6/6 patient. 6/6 patient, except a retinal detachment or a GRT, we don't touch.
I mean, these patients, if it's an only eye patient, I would image them, IFFA, ICG, to see any activity. OCTA might help. So before you inject, we should investigate a bit more. If there is evidence of polyps...
OCTA, if you find evidence is there,
yes,
then...
yeah, we have to explain to the patient.
We have to treat.
Definitely. If the patient knows there's activity...
6/6, minimal fluid, and OCTA, if positive finding is there...
So there's, I mean, yeah, I agree.
So these are the patients where you keep them under close follow-up, sir.
Yeah.
And you keep them the flag signs, that red flag signs, that these are the things you come back early. And once the vision starts deteriorating, so there is a time when you intervene. You don't treat a patient when the patient has a very good vision, because what sir said is right, that you have to explain to him that what are you going to achieve. Your vision is good, but what extra you are going to achieve.
Okay, thank you.
Any other comment? We have one picture and then we will leave.
Sandeepan, can you take a photograph, please?
I think Dr. Kenneth has to take a flight. Yeah. So we will allow him to go because there is no other way. Before he goes, I think all of can take a picture here. So anybody has any more comments or recent usage of faricimab? All of you have used a couple of injections. I would like to hear from Devdulal or Vinay or Nikhil. Your personal experience, because...
Yes. So I just launched 2 months back. So about 6 weeks back, I injected a patient. She had received initially around 14-15 ranibizumab. It was a type 2 CNVM patient. And initially the response was there, then they became recalcitrant, then shifted to aflibercept, then again responded initially, then recalcitrant. Then I gave brolucimab. First injection was a fantastic response. Fluid dried immediately, patient was happy. But after 8 weeks, the fluid started to come up again. And this time, second time I injected brolucimab. At 2 weeks and even at 3 weeks, there was no change in the fluid. And I waited till 6 weeks, and then I offered this injection to the patient. I injected about 12 days back, and day 2 of the injection, the fluid has dried. So I think the other pathways, dual pathways, all probably are working in the patient.
So patient is happy. Patient is happy now. Is he asking that you shift me to this injection?
OCT picture, patient is happy. Vision-wise, there's no difference.
Any other story or, I'll tell you my patient story because I gave in one eye this patient injection, and since the response occurred, so I have now given the other eye also, because he said he comes from far distance. So I have this patient who has both eyes faricimab injection.
This is regarding a DME patient who's never been dry, like intraretinal fluid, subretinal fluid, and some HRF also. And with one Vabysmo, the patient actually has kind of the HRF are gone, the SRF is gone. There's a little bit of IRF left, and there is also some parallelism, if I may call it that, coming back to the eye. So it's like, sir, you mentioned that the pericyte remodeling could be something that's helping all these out. So I think that is something that we need to really.
So what prevented you from giving Ozurdex in this DME patient?
This patient actually has a large cup and strong family history of glaucoma. So
it will be actually very exciting to study, you see, in a DME patient, because both eyes are exposed to same metabolic disease. Then to try Ozurdex in one eye and faricimab in other eye, so as to come out with a clear-cut mandate, which is which.
Right, sir. So the other thing I would like you to request the industry is that they should think about the DME patients, because bilateral, if we are to give faricimab, so that is an area where these 2+3 is not going to be good enough maybe over a period.
Vinay, this 2+3 is not offered to diabetic patients, only for CNV patients.
No, what I meant is for the bilateral cases.
Other eye. So you give this for the patient or for the eye? For the patient. Yes, Arun?
Yeah, sir, even I would like to contribute with one thing, like you were mentioning about the insurance patient. So we do cover the insurance patient under two conditions. One, the annual sum assured for the patient, it should be under 10 lakh rupees. The another thing should be if the
how much?
Annual sum assured under 10 lakh rupees, and the another under 10 lakh.
Under 10 lakh.
Yes.
Under 10 lakh.
And the second thing is required, the patient should be the co-payment condition. So let's say if I am a patient, if I have paid some amount from my own pocket for the Vabysmo treatment, I am eligible for this 2+3 as a scheme.
Some amount means what?
Any amount. We haven't defined it.
1 rupee.
Any amount, sir. We haven't defined. So I think we have kept it to your wisdom, like your jurisdiction. If you want to offer it to
1 rupee, I'll ask the patient to pay. Don't worry.
But sir, that depends upon the insurance company. Insurance company has given the 100% approval.
So I agree. Very good thing you have told is under 10 lakhs and co-payment.
Yes.
Co-payment.
So I think, yeah, sir. So much more patient, probably, you can use it for all your private patient, even for your insurance patient as well. Under this scheme.
I was asking counseling, because the biggest counseling parameter which I use is durability only. You see, that is one parameter which nobody can refuse. That is one parameter which adds to the cost, recurring cost, and repeated visit and repeated things. So I told you that one patient I injected, he got a response in 3 days. He virtually forced me, Dr. Sahab, right eye mein bhi de do aap. So that is one thing. And now he actually is due to go to Canada. So he said, मैं वहाँ जाऊँगा, वहाँ से तो आप यहीं लगा के दे दो. So I think all of us should take advantage of this new injection. And I'm not saying start giving all the patients, but try to study yourself, form your own real-world experience. At least start trying in patients who have recalcitrant disease. Because if your recalcitrant patient responds, that gives you 10 times confidence of starting in a naive patient also. So I have given one in naive patient also, AMD, and I have all the follow-up slides at day 1, day 7, day. So that gives you confidence, because I had response in one patient, so treatment naive I offered. And a lot of these patients are Google-savvy patients. They come with all the data also. So why are you not telling me this? So that's an additional parameter. So long distance, recalcitrant patient, we should go ahead and try. And if you get a good response, you will become confident to give it in naive also. And maybe in the next meeting, all of us have pooled data, and I will request Vinay to have pooled data so that. Because there's an advantage of having pooled data. Pooled data, suppose he does 20, I do 40, you do 20, then cumulative data can be very, very compelling for everybody. So I'll ask Dr. Mishra to say concluding remarks.
So there's a very interesting time for all the retinologists that we have new drugs coming in, which is not only effective, but gives a longer duration of action. So, but we have, as Dr. Lalit said, that we need to pull in our data and create a very solid bank so that we can go for a publication, and the treatment is more justified. And once the data is published, especially from our country, then it not only gives confidence to other fellow colleagues, but also to the patients, because they are also accessing this data. So I will definitely request that we should pitch in together. We should be ready to share our data and create more strong research pool. With this, I conclude my remarks and thank you all for attending this session. Thank you so much.